Welcome to Health IQ. I'm Dr. Alan Siegel, your host. Today we have a very special guest, Dr. Doron Ilan. Dr. Ilan is a hand and upper extremity orthopedic specialist, and we're happy to have you. Welcome to the show.
Thanks for having me.
So, the shoulder to the tips of our fingers. A lot of issues going on there, right? A lot of problems that can happen. But some of the more common things that you probably see are conditions of the hand and wrist, the elbow, I would think, and the shoulder.
Yeah. It's a unique field where we're taking care of anyone from day one age, 1 day old, a baby born with too many fingers or fingers that are stuck together, to the teenager who's pitching and gets elbow pain, to the 50-year-old who falls and breaks their wrist, all the way to the 90-year-old with trigger finger or carpal tunnel.
So it's an exciting field. There's a lot of new advancements in that field. And carpal tunnel, one of the things you mentioned, probably a very common term people hear all the time. They think they have it, they don't know if they have it, they get misdiagnosed with it, so there's a lot of misconceptions about it. Tell us about carpal tunnel, what causes it, and then, when do you know if you actually need surgery for it?
Right. You're right, carpal tunnel is one of the most confusing symptoms and syndromes out there. Actually, I probably see about 4 or 5 patients a day who have carpal tunnel syndrome.
That's a lot, I would think.
Yeah.
So that's a good percentage of what you're seeing patients for.
It's quite a few. And I probably see about 3 or 4 more who think they have carpal tunnel syndrome and actually don't.
Right, it ends up being something different, right?
Yeah, it's one of the most misdiagnosed conditions there are. But basically, carpal tunnel syndrome is a condition where the median nerve, it's one of the nerves that comes out of the neck, goes down into the arm, is pinched in the wrist area. There's a tunnel that on the back of the hand, there's a bony tunnel, almost like an arch, and on the top of that, there's a ligament that makes a real tunnel. And carpal just means wrist, and tunnel obviously means tunnel, so it's actually the wrist tunnel syndrome.
So it's compression of that area on the nerve?
Yeah, exactly. As the nerve goes through the hand and goes into the thumb, index finger, and middle finger, and part of the ring finger, it's getting pinched in the wrist area, and it causes numbness in those fingers. Most people feel it as a nighttime where they start waking up and they feel like they were sitting on their leg.
They slept funny, like a numbness, tingling sensation.
Yeah,
right?
And a lot of them describe it as a burning. Sometimes they feel it's a swelling. Some people, as it gets severe, can actually lose some strength in their hands. That's the typical carpal tunnel syndrome, but unfortunately not everybody reads the textbooks, and some people have different symptoms. Sometimes it can radiate up the arm. Sometimes it can go into the pinky, even though it shouldn't.
So it could actually be, and they have things like double car syndrome where they actually have a cervical problem that's compounding the issue, and you don't always know if it's actually a neck problem or coming from the hand, and you have to differentially diagnose, is it a neck problem, is it a wrist problem, or sometimes in between, so brachial plexus.
Correct. So that's one of the most difficult parts of my job, or the person who comes in who has neck symptoms and is having numbness in their hand that kind of seems like carpal tunnel, but it also seems a little bit like neck. So with a good physical examination, I'm usually able to figure out which one it is.
Right.
And if I can't, and we usually send them for neurological testing where they'll do electrodiagnostic tests, which are called EMGs and nerve conduction studies.
Which is the gold standard kind of for that diagnosis that really pinpoints exactly where the problem is, or it should, or hopefully.
Correct. It really helps us. It also can grade whether the nerve has really been damaged over time or whether it's just sort of like a current pinching. I like to think of it as somebody's like choking on somebody's neck, and it can be a light choke or it can be a heavy choke, and eventually it can cause you to stop breathing. And the same thing with carpal tunnel, eventually the nerve can die.
Right. And that's when we start talking about procedures. That's when we're talking to the patient about, okay, we've done some conservative care, we've tried some other things, we've tried some rehab or some other exercises. It's not working, your symptoms are getting worse, the nerve could be dying, as you say, or choking. What do we do? Let's talk about the procedure. I know we're going to show a little video in a second, but what's the latest technology? Because I've seen patients where in the past they've had very large cuts and scars, and it's changed a little bit, which is good, I believe.
Correct. Fortunately, a lot of times when people are early in the condition, we can treat them with a splint. Sometimes a cortisone injection can get them by. And then typically we start thinking about surgery when their symptoms either get to a point where they can't sleep at night, they're intolerable to them, or their nerve tests show a condition where the nerve is really damaged and we're worried that they could never regain their function if we don't do something soon. Then we do something called the carpal tunnel release. During a carpal tunnel release, we basically go into the wrist through, in general, a relatively small incision, and we're going to talk a little bit about a minimally invasive procedure that we can do a very small incision. And we basically enter the wrist and we divide the ligament. That's the top of the carpal tunnel, and it sits on top of the nerve, and it basically opens up the nerve and allows there to be more space. So we're basically taking our hands off of the person, off of the neck, to allow the nerve to breathe.
The smart release endoscopy procedure, this is the latest and greatest in terms of technologies, or for this type of procedure you're describing?
Correct. There are typically two types of procedures that can be done with this. The first is an open carpal tunnel release, where a 1-inch incision is made in the palm of the hand. Patients typically do well, and that's the gold standard that's been used for years. The problem with that procedure is a lot of people, the location of the incision can bother them. You're dividing tissues that don't necessarily need to be divided to get down to the carpal tunnel, and it can lead to longer recoveries. And you'll hear people saying, oh, my friend had carpal tunnel syndrome and they had pain in their hand for a long time. So we have a newer technique that's actually been around for probably 15 to 20 years and is becoming more prominent now. Not a lot of people are doing it because it requires a little bit more skill, but we go in through a much smaller incision in the wrist area, not in the palm of the hand, but in the wrist, and we insert a endoscope or a video camera that's very small, and we insert it underneath the ligament, and then we cut the ligament from the inside out, so we don't have to divide any of the tissues on top.
So an endoscope that almost similar to what you might have in another type of procedure, like a camera procedure?
Absolutely. We use a little video camera that has fiber optics,
so
and we look inside. Yeah, it allows us to pinpoint exactly where we're going. And there's a little blade on this device that comes from the inside, and we divide that ligament, and it releases it. And the nice thing is, because we're not releasing all the tissues on top of the ligament, they have less pain afterwards, they have a quicker recovery, their scar is also in a better place. If you think about where the typical carpal tunnel incision is in the palm of the hand, that's where somebody holds a hammer, or they hold a golf club. And with the incision in the wrist area instead, which is smaller, it heals very nicely.
Plus they can function quicker.
They function quicker. They function quicker. It's not the ideal procedure for everyone, but it's very good for procedure for people who need to get back to work a little bit quicker. And we've been very successful with it.
With all these new technologies, typically the more recently trained orthopedics possibly have gone through this training, have decided that they want to try these more minimally invasive procedures. So,
correct.
So that's great. So obviously that's one very common condition. 4 out of 5 patients a day just with that. I have to assume tennis being a popular sport, you see a lot of tennis elbow, golfer's elbow, conditions of the elbow. Tell us about that, because there's a lot of variations in those conditions as well, whether they're surgical, whether they can be treated conservatively. I know sometimes they're chronic for a lot of people, and they have trouble getting better. So how do you address that?
Tennis elbow and golfer's elbow. A lot of people think you have to play tennis or you have to play golf to get these. These were actually cleverly named by doctors who ran out of things to name themselves over, so they started naming about other stuff. But truly, the majority of people who have these conditions,
favorite sports, right?
Yeah. Truly, the people who have these things don't even play these sports for the most part. Tennis elbow, it is very common in tennis players, but the vast majority of people I see with this don't play tennis. And basically, what tennis elbow is, and golfer's elbow is the same exact thing on the other side of the elbow, is a tendinosis, which is a damage to the tendon as the forearm muscles, which bring your wrist up and down, insert into the elbow region on a bony prominence. And where it's inserting there, it just gets damaged over time.
Repetitive stress, injuries,
repetitive stress.
People that are doing the same thing over and over again, like whacking hammers or using screwdrivers, work-related in some cases.
They're certainly more prone to it, but even people we don't even realize in our daily life, you go to your refrigerator 15 times a day and you're picking up the orange juice, and that even puts stress on it. We're not exactly sure why the condition happens, but we think it's due to a tendon damage that doesn't get healed because there's a poor blood supply in that area. Generally, that area has a poor blood supply, and in some people it may be a little bit worse, which may lean them to be more likely to get tennis elbow or golfer's elbow. The problem with these conditions is they can come on all of a sudden, and they can drag on and drag on and drag on, and they're very difficult to treat because no matter what we do,
patients get frustrated because they're looking at their elbow like it's just this one spot, doc, and it's like, but it keeps bothering you, and whether it's physical therapy or ultrasound or stim or PRP therapy or other types of conditions, it does get frustrating. Cortisone injections, they work, they don't work, so it is frustrating for all providers, I think.
The key is that most of these patients do get better within a year's period of time. So when a patient first comes in to me, they've had it for 6 weeks, and they always say, I don't usually come into the doctor for this stuff, but it's been 6 weeks, it's a long time. And then I tell them, well, it's probably going to get better on its own, but it will probably take 6 months to a year, and they don't like that. So we've come up with a lot of different techniques to try to make this better. Cortisone injections are very helpful for dulling the pain for a while, but it's really a Band-Aid in Not in all conditions, but in tennis elbow, it's really a Band-Aid. Usually it'll come back at some point.
So would you agree that cortisone isn't necessarily a healing mechanism?
Absolutely not.
It's not. If anything,
it
deteriorates it could deteriorate the tissue even worse, depending on if it's done too often or whatever.
It's possible. And the studies have shown that people who get a cortisone shot versus the people who don't, if you look at them at 6 weeks after the shot, the people who got the shot are definitely doing better because the cortisone is still working. But at 6 months, the same number of people are better or not better, whether they got the shot or not. So it's definitely not a healing thing. Some people think they're cured because the shot lasts about 3 months. If their body happened to get them better in the 3 months,
but sometimes it helps. People want to get out of pain, function a little bit better, and just to kind of get through the weekend or whatever they got to get through. So
it's a great treatment option for somebody who has stuff to do, and they don't want to just wait it out. They want to feel better. Therapy is extremely helpful, I've found, in a lot of my patients. It doesn't work for everybody, but it's a great thing that you can actively do to get it better. There are straps that you can wear which help you while you're playing tennis or your activities, but they don't cure it either.
You see all the bubbles out there, and everyone's putting the bubbles on.
Exactly.
Well, therapy is about, I'm sure you're familiar with active release technique. I think that's a pretty good mechanism for this type of condition, especially when there's a lot of adhesion and scar tissue and tightness along those. It's not always just that one area. You have to loosen up all of the triggers along the flexor and extender tendons and loosen up the whole forearm, the whole backside of the arm, just to help that one area, because that area is so stressed that everything else is starting to tighten up too.
Everything else tightens up,
so we've had
I found therapy is great for that, and the active release is a wonderful technique for that
and
as well.
The more serious conditions, when you have to think about a procedure, because after all, you are an orthopedic, so you do have to always consider, when do I have to do a procedure on a patient? So what is going on in terms of the latest technologies or procedures for tennis elbow? 10X is a type of procedure, if you want to describe that a little bit.
Yeah, typically we try to wait at least 9 months to a year for a patient to start undergoing any invasive procedures. The main invasive procedure that we've always used.
So they got to deal with this for 10 months before.
A lot of times they do, and that's where 10X might come in to play for some patients, because we don't want to do an open procedure where we're actually making an incision over the elbow and cleaning out the tendon for a while, because that's a long recovery as well. So there is a new technique. It's called the 10X fast procedure. And basically, it's something that we can do early along in the process when patients are not getting better with the therapy or the injections. And basically what we do is we take a small probe. It's about the size of a pen, not the big part of the pen, but the inside of the pen, the little pencil or lead pencil part. We make a very small incision over the side of the elbow, and we insert this probe under an ultrasonic guidance. So we're actually looking inside with the ultrasound, and we target the damaged tissue, the tissue that's what we call tendinosis. Tendinosis is damaged tendon tissue, and we target that, and this little device goes in and basically dissolves the bad tissue, and it allows new blood supply to come in and bring the healthy tissue together. It's basically enabling the body to heal quicker.
So you're like cleaning it out a little bit, basically, and then you're trying to bring in the proper healing cells to that area to promote healing.
Right, because in tennis elbow you get this bulk of tissue that's damaged tissue, and the blood supply just can't get in. So by doing this procedure with a very small little incision, you can actually clean that out, and that allows the good tissue to come together and heal it back together.
What about damaged tissue versus torn tissue, like actual tears where there's nothing attached to the bone? Is that a different procedure entirely, like an open procedure? You have to reattach something? Or?
For the majority of cases of tennis elbow, it's not a fully torn tendon, it's partially torn tissue and chronically damaged tissue. And the nice thing is that you don't need that insertion of the tendon into the bone to be complete. It's got a very broad insertion, and one of the older procedures that people would do is they would just go in and cut the whole insertion to make people feel better, and they actually felt better. So in most cases, when we're not dealing with a complete traumatic rupture of the tendon, we can go in and do a procedure where we just clean up the tendon rather than going in and repairing it. In some patients where you have a complete tear, they had a bad injury, they heard a snap in their elbow or something when there was an injury, then they have a complete tendon rupture, and that usually needs to be repaired in order for them to get better. But in the majority of cases, even the open surgery that we do for this, that we do after a year or 9 months, is basically going in and cleaning out that tissue. And this technique allows us to do that earlier.
And this is both sides of the elbow you can do this on?
Yeah, you can do it on both sides of the elbow. It can actually be done for Achilles tendonitis. It can be done for patella tendonitis.
So it's a procedure that for different tendon areas that's very effective.
Yeah, it's been out there for about 2 years now. And the one negative of this procedure is we don't have long-term studies showing its effectiveness. But we do have several good case studies showing that it does seem to be effective. The great news about it is there's really no big harm to it because it's a tiny incision.
It's a very minimally
we put a Band-Aid on it afterwards, and if they're going to get better, they usually get better. If they're not, you didn't lose much.
Right, and so sometimes science needs stepping stones. You have to have certain procedures and learn along the process, and that's just the way it goes to advance these things.
Absolutely.
Now in the shoulder, obviously, rotator cuff problems, adhesive capsulitis, frozen shoulder. In terms of getting people injections in the shoulder, I think you do some ultrasound guided procedures as well. Are those just cortisone injections or other types of treatments for the?
Typically we've gone in and done most of our injections blind. So we feel the bony landmarks and we go in, and a lot of times you'll put a cortisone shot or any injection, whether it's a visco supplementation, which is often used for knee arthritis and things like that.
Are they doing this in the shoulder as well now?
Yeah, well, they're not doing a lot of the visco supplementation in the shoulder.
Right.
Because most of the problems are, in the knees and the hips.
I know we're talking about the arm, and because that's especially, but I realize that your group does full body orthopedics. So
correct.
But the ultrasound does help get you into the right.
The ultrasound allows us in some places you don't need it, but in some parts of the body, we've started using ultrasound, which doctors are now using, orthopedists are now using in their office, kind of like a stethoscope that an internist would have.
Sure.
We're using that to look inside the body without having to get an MRI. And when we're doing injections, it actually allows us to target exactly where we want to go. So we can look at the spot where we want to go. We can look at where the inflammation is. We can look at where the small joints. A lot of times I inject small joints in the thumb or the wrist. And when you're doing it without the ultrasound, to some extent, there's a little bit of guesswork, and you may not be as accurate. And with the ultrasound, you can target exactly where you want to go. It's pain-free, the ultrasound. And actually, by doing the ultrasound, since you're targeting exactly, the injection's usually less painful, and it's more effective because you're more accurate.
Now you're using this for procedural work. Now, ultrasound diagnostically has become more prevalent in the industry. MRI is still kind of the gold standard of certain types of conditions, but can ultrasound be used effectively for musculoskeletal diagnosis?
Very much so.
Yeah.
Very much so. It's a very effective tool. MRI is the gold standard. There's no question. I send a lot of MRIs out. The problem with an MRI is, number one, it's expensive. The insurance companies usually require authorization, and sometimes they don't give it.
Right. And you as a doctor want immediate feedback or want some visualization of what's going on.
Right. An MRI can take 2 to 3 weeks to get sometimes, depending on the insurance complying with us and giving us authorization to do it. And then a lot of patients are claustrophobic, and the MRI machines a lot of times are